Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for health professionals in Aotearoa, New Zealand. In the series, we're looking at key medico-legal issues in our jurisdiction, and today we're looking at a case from the HDC regarding a case of pulmonary embolism. So my name is Dr. Tim Cookson. I'm a consultant for medical protection, and I'm joined today by three colleagues, two from general practice, Dr. Sam King. Hi, Sam.
Hey, Tim.
And Dr. Lucy Gibbard.
Hi, Tim.
Both of whom are medico-legal consultants at Medical Protection, and also good to have Adam Holloway here. Adam's a partner at Watt & Kearney, our panel firm of lawyers. Hi, Adam.
Hi, Tim.
So, today's podcast discusses an HDC case published about a year ago in which a GP was found to be in breach and two colleagues and the medical centre received adverse comments. Now, as usual, we're not going to be giving advice on clinical management, but having an understanding of the clinical scenario is actually critical for our team, for example, when advising members in cases like this. It was a tragic case with a fatal outcome which was almost certainly preventable. It's also a case where various biases were probably present, and it's worthwhile thinking about these and how they can influence our behaviour. So on her first presentation, Mrs. A, a woman in her 60s, went to a 24-hour clinic. She had a 3-week history of worsening pain and swelling in the back of her left knee and calf, and said that her leg was red, warm and painful. She gave a history of some overseas travel 3 or 4 months beforehand, and she also reported increased shortness of breath on exertion over the last month. And in fact, the doctor who saw her observed that she became slightly short of breath just walking to the treatment bay and made a note of it. Examination was entirely normal, apart from a raised pulse of 105, and the leg certainly was swollen, red, warm and tender. No respiratory rate was recorded, despite the observation of shortness of breath walking to the treatment bay. So without applying a hindsight bias here, Sam, what are your thoughts on this presentation?
Oh, it's clearly a DVT and PE. There's no hindsight bias whatsoever, Tim.
No, well, you're a particularly astute doctor, Sam. That's well done.
Look, it's really hard to not have hindsight bias. When you know the answer, it becomes really obvious. But when you're the clinician seeing the patient at that moment, I don't know, things look very different, or they can look very different.
It's also writing it down like that. You know, it kind of makes it clearer sometimes than having a patient in front of you where the history is a bit more muddled than it actually looks like it on paper. And you read it back afterwards, you think, oh yeah. But actually when you are there in front of the patient, sometimes it's just not quite so obvious.
You're right. And if she was a difficult historian, which many patients are, obviously, they jump around from this topic to that topic and any other symptoms, and they'll tell you about something completely unrelated. So putting those things together can be a real diagnostic conundrum.
Lucy, hindsight bias is a real problem when we're going over our cases where we know the outcome, as we've discussed. And the earlier information prior to the final diagnosis, for example, it's interpreted with that outcome in mind. And it's something that we observe from time to time in the expert opinions that we read as well, and which we will always challenge when we spot it. But actually, while I think we're all aware of the term, what's the actual definition of hindsight bias?
Thanks, Tim. So look, according to the Encyclopaedia Britannica, that well-known tome, it is the tendency upon hearing an outcome of an event to overestimate one's ability to have foreseen the outcome. So that's exactly as Sam has just demonstrated. The phenomenon was first described and in the 1970s by psychologists who were investigating errors in human decision-making. They asked people trivia questions or had them make predictions of political elections, and the participants were later asked to recall their predictions. The hindsight bias was evident when people overestimated the accuracy of their predictions. Subsequent investigations into the causes and consequences of hindsight bias determined that the phenomenon was widespread and difficult to avoid. In looking at cases, this might lead to only the clinical indicators that were consistent with the final diagnosis being considered, not taking into account the negative findings and their significance at that time. So it's that whole thing of it's all so easy when you look back knowing the outcome, isn't it?
Yep. And that's certainly what we see for some of the expert opinions, that they've clearly used information that came later and decided that the doctor or clinician should have taken a different action, even though they didn't have that information at the time. So the A&M doctor's clinical assessment was very similar to Dr. King's, and he decided that it was very likely to be a DVT and wondered about the possibility of a pulmonary embolus. Organised appropriate investigations, which showed a D-dimer of 2651, with the normal being less than 500, and on ultrasound there was a below-knee DVT. She also had an ECG done, which was normal, with no changes suggestive of pulmonary embolus. He started her on Clexane and dabigatran and referred her back to her GP. So, Sam, any comments on the management plan, and is anything missing from the management plan?
Well, I'd be interested to know what he thought about his shortness of breath, if she was noticeably short of breath. So even if there was normal ECG or no changes that he could see, you've got to ask that question. If she's got a known DVT now, and you've got to say there's a high risk that she was having a PE. And I would have thought, in fact, he might have investigated that a little further. I also noticed that I don't know whether he gave her any safety netting advice.
Don't recall the safety netting, other than that she was to see her GP in 3 or 4 days' time.
Was there any other reason present for the breathlessness that's not recorded? COPD or...
No past history, and she was a non-smoker.
One of the things about that ECG, though, it's been recorded as not, I assume it's not showing that S1Q3T3 thing that you're supposed to be able to see in PEs, but I thought the commonest ECG finding on a PE is actually a sinus tachycardia, which she had.
She had a tachycardia,
She did have any... Oh, did she not have it when the ECG was taken?
That wasn't recorded.
Right.
But during the time that she was there, her pulse did settle to about 80-odd.
Right. Yeah, because that's...
Still up a bit, but not as high as it had been.
Not as high as it had been, because I think that would have kind of... Yeah, with my hindsight bias, I'm thinking, would that have made me think about it?
But you also think, patient a bit anxious or whatever.
Yeah, exactly.
So elevated pulse is pretty common. And the fact that it settled later on would make you kind of discount the tachycardia as being a significant thing. So
totally.
So interestingly, when asked about his management, the accident medical doctor stated that because the treatment was the same for DVT or pulmonary embolus, he wouldn't have changed his management. Interestingly, though, he didn't use any scoring system for PE, so he didn't take any formal steps, if you like, to rule out that possibility. And in fact, when you subsequently do the testing, either the PERC, P-E-R-C, which is a PE rule-out criteria, or an RGS, which is the revised Geneva score. So the PERC indicated that a pulmonary embolus could not be ruled out. And in fact, the Geneva score suggested a 20 to 30% likelihood of pulmonary embolus. And I think if the doctor had done those two tests, his actions might have been different. So, Lucy, any comments on that and pathways and things like that?
Well, I think the doctor's saying, because the treatment is the same, did I in that situation need to make that distinction? Is that correct? Because I think
that's what he's claiming, that he didn't need to, because his treatment had covered both.
Because his treatment had covered both.
Yeah.
And look at the end of the day, you can see that when you're in that situation and you're maybe not thinking as clearly about the long-term issues, that in the acute situation, you're thinking, well, I'm treating it. Having
Except
said
that she is significantly short of breath.
Having said that, yes, I think that's me trying to see it from his point of view. Look, at the end of the day, the Health Pathways guidance is that she should have had an urgent CTPA. If you think there's a PE there.
Yes, and to have recorded query PE
and not to then go on.
followed that up does seem to be a bit of a gap, and sometimes it also reflects that inability to kind of think one step beyond perhaps what you've got. And in talking with students, I would often say to them, one thing I'd really like when I was working well would be to think, what's the worst case scenario here? What's the one thing that I wouldn't like my patient to leave this consulting room with that I haven't dealt with appropriately? And so that's sort of pausing and thinking about it beforehand. And look, when you're in a busy clinic, that's the kind of thing that doesn't happen. But certainly there was a gap there.
I think that when we find a diagnosis that fits with what we think is going on, we tend to stop thinking at that point because we found what we think is the answer. And I mean, that's a bias, isn't it, that we have. And as you say, when you're busy, you've got 15-minute appointments and you've probably got a waiting room full of people. It can be, I can see how it happens very easily, where you don't think beyond.
And also for an A&M doctor, might be thinking, well, as you say, Lucy, I've got the urgent things covered. She's on the click saying, yep, and we'll starting the bigger trend. It's actually not my role in an A&M situation to organise further investigations. And maybe she does need to go in for an assessment for a PE, but that's something the GP can do because the patient's sort of covered in the meantime. So there's a number of potential explanations, I guess. So she presents 3 days later to her GP as planned, who wrote pretty good notes. The patient had very good oxygen saturations of 97%, still had a bit of a tachycardia, pulse of 103. But her chest was clear, there was no ankle swelling, JVP was normal. Now, the GP wondered about congestive heart failure as a cause for the shortness of breath and organised an X-ray and BNP, and these were both normal. And it turns out that although she never recorded it in the notes, the GP had gained the impression that the shortness of breath on exertion had significantly preceded the other symptoms of the DVT. And so in her mind, she was separating these things out as being two separate processes rather than the same one. And this certainly seems to have influenced her thinking on and off through the case. On the other hand, a PE was still on her mind, as on the chest X-ray request form she wrote, query CHF, query other chest lesion, low risk but query PE. And I'm going to apply some hindsight bias here, but I think the GP started to show signs of confirmation bias. So here's another one. Sam, would you like to give us a definition of confirmation bias?
Sure. It's people's tendency to process information by looking for or interpreting information that is consistent with their existing beliefs. This biased approach to decision-making is largely unintentional, and it results in a person ignoring information that is inconsistent with their beliefs.
Lucy, do you think there are any factors here to back up my assertion that maybe confirmation bias was going on?
Yeah, well, look, she thought that the respiratory symptoms had preceded the DVT, and so that's why she was thinking, what is another cause? Because she had clearly thought about a PE. Looking back in the A&M record, it was actually clear that they hadn't. But also the A&M doctor hadn't thought it was a PE. He hadn't, or she hadn't requested a CTPA then. So maybe that sometimes when your colleague has already headed down one track, you're just going to go on the same track as them. And maybe that the confirmation bias was actually that she was going along with what the A&M doctor had actually thought. And they thought the PE had been excluded.
A layperson's question for the medical members of the panel: is a chest X-ray diagnostic of PE? Because
No, but she was doing it to rule out congestive heart failure, which will often show up on a chest X-ray, but not always.
And having put query PE on a request for an image, albeit a non-diagnostic image, for what you're wondering about, any responsibility on the radiologist at that stage to say, you've queried this, we'll need to do a different sort of test?
Yeah, well, in an ideal world, if the radiologist saw that, it would be nice if they actually wrote, you see, chest X-rays are not the right modality to rule out a PE. If this is a concern, please request further imaging. That would be in an ideal world. And sometimes we get those things back, but often not.
I guess the other thing there is that on the request form, she had written, first of all, query heart failure, query other chest lesions. So, she clearly had those other things in mind. If it had just been chest X-ray, please, query PE, it might have been different.
Or
but
if she'd written known DVT.
Known DVT, exactly. That's what I was thinking.
That might have changed things.
It's interesting, though, what you write in the request. I've had a case where, whether or not the patient was postmenopausal was relevant to the findings and the report. And it is really important what you write in your request form,
Yes.
that actually forget for what you get back.
Yeah, because it focuses the attention of the radiologist.
Yeah.
When you think about the short time they have to review images and come up with a report, if you don't focus them, when they look at it, they don't focus. Yeah.
Yeah, so the more information, I'm not sure that the radiologist would have done anything different on the chest X-ray report, even if she had noted that there was a recent DVT. But
I have to confess, this is many, many years ago now, probably decades ago. I wrote out and I requested a chest X-ray form for a patient with known lung, CA, multiple lesions on her lungs, but I forgot to put that bit on the form. And the radiologist was incredibly polite when he called me to because he was really worried, thinking, oh my gosh, this woman's got multiple lung lesions, she's got cancer. And when I told him, oh yeah, no, I know that, he was incredibly polite and said, well, gosh, that would have been helpful. Helpful to know that detail.
Indeed. So, Mrs. A's symptoms all settled, and she completed her 6-month course of dabigatran. But 14 months after her initial presentation, so at which stage she'd been off the dabigatran for at least 8 months, she presented to her GP with acute left leg pain and a feeling of heaviness in the leg, but there was no shortness of breath, though she did say she'd been on a recent fairly long car trip. Examination was good, there was no leg swelling, though interestingly the GP recorded a Wells score of 3, which is high risk for DVT. Interestingly, Dr. Mapleston, when he reviewed the same information that was in the notes, didn't come up with a score that high, and neither did I when I was looking at it. But nonetheless, she organised for D-dimers to be done, and these were elevated, 1140, so perhaps not quite as high as the initial time presentation. So she organised the scan, and that showed no femoropopliteal or calf DVT. And so no further investigations were done at that stage. So Sam, this patient's got an elevated D-dimer. She's got no DVT seen on scan. Are you reassured that nothing more needs to be done? And because, are there other reasons why a D-dimer might be elevated that are not related to, for example, a DVT?
Yes, there are a number of reasons for a raised DVT, any kind of inflammation or heart failure. And I'm sure there are a few other things as well. But an 1140 isn't excessively high.
It's abnormal.
It's abnormal, yes.
abnormal.
But I've seen plenty of patients. I've done plenty of normal Doppler scans on patients with a D-dimer at this level. And so I don't know. I mean, she's got no shortness of breath. And so I don't know that I would have taken it any further. Am I wrong, Tim?
Well, there's the issue that is in the pathways that, a certain percentage of DVTs can be missed in the early stages. So the advice in the pathways is to repeat the scan if symptoms don't settle quickly. And in fact here, there were no further reports of pain. There was no direct follow-up, but the woman didn't come back saying she still had her pains. And so Dr. Mapleston, in fact, found that was reasonable as an approach for her not to take any further action at that stage.
I'm wondering whether, I'm just thinking about funding for a scan under POAC, if you have a negative one, whether you can get another one a week later. I'm not sure what the POAC funding says for that, because I don't think it often happens. I don't think people get repeat scans on a negative scan that often.
Apparently that's in the pathway that this particular doctor was able to access. So
I think
hopefully...
if patients have ongoing symptoms, then you can get one. That's my experience.
So you can probably get a new POAC number, can't you?
So interestingly, she had this symptom, had the D-dimer and the ultrasound, and then came back in for two or three other consultations over the next wee while, and there's no mention at all of asking about those earlier symptoms. What are your thoughts on this, Lucy? Do you think that would have been a reasonable thing, or is that one of those things that it's a nice to have, but in the context of a busy consult?
Oh, look, I have to say I've had several cases with members where this has been an issue, where the doctor hasn't looked back at the previous symptoms and hasn't brought them up when the patient hasn't then volunteered them in subsequent consultations. I think that often the HDC does expect that doctors will have looked back at least into the recent consults and made some inquiry. But the reality is, in general practice life with your 15-minute consult, when the patient presents with 2 or 3 new things in a consult and you're using more than your 15 minutes, I'm not sure in what time you are supposed to then go back and look at the old notes and ask them about other problems that they haven't volunteered on this occasion, because, I mean, it is just...
Yeah, the assumption is that they no longer have symptoms.
But I think the HDC do criticise for not looking back. In fact, I know they do.
And there's also the possibility that the questions may have been asked, but because the response was no, I haven't had any symptoms, that it wouldn't be recorded.
I'm actually a little surprised by the number of GPs that say that to me, that they don't record negative, negative inquiries, negative responses. And there is definitely a risk for that, because you can't demonstrate you've turned your mind to whatever it is. You turned your mind to the possibility of an MI or a DVT or a PE.
It's also very helpful for another colleague who's coming after you, because you might know the patient well enough to recall the negative findings, but it won't necessarily be you. And there certainly are HD cases that I've seen where people have been criticised for not recording negative findings.
It'd be interesting to see with the AI scribe system whether that's going to get better, whether the AI scribe will be better at recording negative findings.
Yeah, it's interesting. I was talking to a member the other day, and the patient has said, I definitely told the GP this. And the GP said he definitely didn't. And the notes are very good. And as it turned out, the GP has used one of those AI scribes. And so had the patient mentioned it, it would definitely have shown up in that clinical note.
Would it? Because the way they're trained is to pick up on medical things, not necessarily everything. And that's one comment that Richard Medlicott made about them, is that they'll often miss out the kind of the social things, which are actually very important in a clinical consultation.
Yeah, in this particular case, it was definitely a symptom. Right. And because the notes were pretty detailed, they were really good notes, actually, I have to say. And that part was missing. And you can actually go back and find the transcript, the entire transcript. Well, actually, I don't know about Heidi, but depends. I know NABLA you can.
It depends whether you've clicked the button for whether, I'm not sure about that.
Okay. On NABLA, you can see the whole transcript, and it will keep it for a certain period of time. But yeah, it was something that it would be hard to believe that it would not have been picked up and captured in the notes, what the symptom that he complained about, or he says he told the GP about.
Certainly there's a real advantage in general practice for when you are organised and things are going well, before you see your next patient, just to have a quick look at their notes and then pick up if there's anything there. And then that's often a really good introduction to the consult. You had such and such last time. What's happened with that? And then writing just a 2-word, Essex gone or whatever.
Abdo pain settled.
My
the other thing
memory's
it does,
so bad. I have to look back, even if it was yesterday.
yeah, but the other thing that's really good about that is that patients then really like it that you've taken the time to actually look back and followed up on that came last time. And so it's a very valuable doctor-patient building relationship.
I had a case, this is a few years ago now, where the GP had his PMS set up where he couldn't see the problem list or the medication chart on the main screen. It was on a separate page. And because he didn't look back at any consults, he only had the current consult on his screen, he forgot that the patient had hypertension and that she hadn't asked for her medication for a long time, a couple of years in fact, and neither had he taken her blood pressure. And she ended up having a stroke. And in this particular case, interestingly, he wasn't found in breach, but he was criticised that he hadn't looked back in the notes. And I think it's actually a rather big miss for a GP.
And we might come back on to that topic of availability of information. The next consult was during COVID level 2, so it was done by telephone, and it was 6 months after the previous consult with the leg pains. It was also to a GP colleague at the practice rather than her own GP. And on this occasion, Mrs. A reported 2 or 3 episodes of shortness of breath on exertion and intermittent leg swelling, which previously she said had been attributed to venous insufficiency. Now, interestingly, the GP who did the teleconsult recorded the recent history of the elevated D-dimer and the negative ultrasound, but didn't make note of the proven DVT which had occurred over a year and a half previously. He organised a test X-ray because of the shortness of breath and did a D-dimer, which was up at 4499, so certainly abnormal. But although most other causes for an elevated D-dimer had been excluded, he said he didn't suspect pulmonary embolus, as he said Mrs. A had a low PERC score, the PE rule-out criteria. In fact, that was a misunderstanding. There's no such thing as a low PERC score. If you have any of the points on the PERC score, that means that pulmonary embolus cannot be ruled out. And in fact, she had 3 things.
Wasn't even low.
Wasn't even low.
Right, okay.
Yeah. So again,
I think that isn't the PERC only used for low risk PE, whereas if you've had a previous DVT, or you say that he wasn't aware that she'd had a previous DVT.
He wasn't.
Well, he may not have been aware because he made a note of the previous leg pain and normal ultrasound, but not of the previous DVT.
Oh, okay.
Yeah. Sam, virtual consults are still a pretty regular part of overall general practice. Is this a case where face-to-face consults ought to have been considered?
Without my hindsight bias, I would say yes.
Even without hindsight bias?
I think the Medical Council in their statement says, consider whether a physical examination could provide information that will affect the patient's diagnosis or management, including their treatment or whether to refer for further investigations. And I think, for a lot of us, we have different thresholds, I guess, for when we feel we need to see a patient. But if you've got a patient with leg swelling, raised D-dimers, you've been worried, shortness of breath, and all of those sorts of things, you can't actually determine the level of those things or whether they're significant unless you examine the patient physically. And, a lot of patients, and I think she was 60, was she 60,
in
something
the 60s,
like that? They're not necessarily able to tell you or describe in detail even the history necessarily accurately. And so I think it's really important that you examine a patient when you have uncertainty.
And do you and Lucy have kind of critical key symptoms where you'd say, oh yeah, this patient always needs to have a consult, face-to-face consult? Are there certain triggers that you would say, yep, definitely needs to be seen? Chest pain, crushing chest pain.
Yeah, central chest pain is usually a biggie.
Yeah.
I think shortness of breath as well.
Yeah, I would have thought that would come into it.
Yeah, and even like abdo pain.
Yeah.
Could be,
How do you know?
How do you know? It could be anything. Actually, most things I tell them they need to come in. Often with telehealth these days, the types of patients that I tend to see that way would be, I've had the flu, I'm better now, I just need a medical certificate, or I just need a repeat medication, and it's something fairly simple. They're the patients that I would tend to do by telehealth. Other patients, I ask them to be seen.
So you're not doing a lot of diagnosis via telehealth, yeah.
And I think physical symptoms as well is the thing. It's very hard to assess physically if you aren't physically there.
Yeah, and although, we know well that we're mostly correct on our diagnosis when we take the history alone, but on the other hand, there are times when examination will certainly change the diagnosis,
maybe it's
change the
actually
management.
if you have a diagnosis, because it's not clear what the diagnosis of this elevated D-dimer is. And maybe one of the rules should be if you don't have a diagnosis, that is a time that you should actually be examining your patient.
Well, the reality is the D-time has gone up considerably.
It has.
Yep.
It's a decent D-dimer, isn't it?
It is.
Yep, there's no explaining that one away. And look, certainly the HDC was critical that no face-to-face consult was arranged. Interesting, I think that this doctor also showed confirmation bias, that, he had seen that there was no previous DVT, and so therefore didn't think to follow that up. It was certainly an issue, I think, for him. He probably also had an assumption that with the elevated D-dimers that pulmonary embolus must have been excluded previously. I think that'd be an easy assumption to make, knowing that this patient had had consultations previously, even though he didn't actually apparently know about the DVT. So 2 weeks later, there was another telehealth consult, this time with her usual GP, and the history again was of shortness of breath, but to the point where Mrs. A was scared to go out for a walk because of the shortness of breath and the sweating and the feeling of weakness that occurred when she got it. This time the GP was much more concerned about the possibility of PE and decided to refer her for an urgent CTPA. Sam, any thoughts?
I assume that was by ambulance via ED, was it?
Well, no, and we'll come to that. So that's what you would have done. Pathways certainly suggested that, that was an indication for admission.
Well, the patient history alone is really concerning. Shortness of breath to the point where she's scared to go out. She's sweating and feeling weak. I would have thought if he's thinking she doesn't need to go now, then she ought to come in and I need to see her now.
She has that D-dimer of 4,000 as well.
And yeah.
Exactly. Yep.
So if it was an outpatient CTPA, I'm not even sure if GPs order those.
Apparently not, but the GP apparently thought that she could.
Okay.
But mistakenly ordered a CT chest rather than a CTPA.
Okay.
Now, it was sent off the same day. Within hours, the referral was rejected by the radiology department. But interestingly, even though the request stated query pulmonary embolus, the note that came back with a rejection directed the GP to the CT chest pathway rather than the pulmonary embolus pathway. The GP unfortunately took no further action and didn't actually inform Mrs. A that the request had been rejected, and she was actually found in breach for both of those inactions. Any thoughts about that advice from the radiology people? It's apparently a doctor who reviews them and wrote a quick note to say why it was being rejected.
Yes, it's unfortunate that the indication for the request wasn't considered in the fact that if that radiologist had actually thought about it and thought, oh, maybe she actually is wanting a CTPA. But equally, the radiologist may have thought, well, GPs can't order CTPA, so she must be requesting a CT chest. That's the only thing on our pathway, so I'll send her that way. It's just hard to know what was going through their head. It would have been nice if the radiologist had said the right investigation is a CTPA, and you need to send this patient to hospital if you think they've had a PE.
Yeah, and in fact, the HDC thought about that issue, didn't make an adverse comment, but did ask the DHB to think about the kind of advice that they give in that situation, and the DHB subsequently changed their advice to account for this kind of thing, where it addressed more specifically the clinical concern, even though there's an error in the request.
At my local hospital where I work, there is a radiology liaison doctor on during the day. And so I assume they haven't rung them for a long time, but you can ring and just explain the situation and they will decide whether they can just take them directly to radiology. You don't have to go through ED. So I don't know whether all of the hospitals have that, but they certainly have that at where I am.
There are a number of different systems, I think, around the country. I know in Wellington, in the afternoon, if you ring up and want clinical advice, you'll get the consultant on rather than the registrar that you want to talk to.
Oh dear, now all the GPs know that. The poor consultants are going to get a lot of afternoon calls.
But the consultant actually say it saves them time.
Yeah.
Because they get the information directly.
Yeah.
They don't get it via the registrar and then have to ask questions and go back again and things.
I think
good decisions are made.
They did that at Middlemore as well, where a number of the people on the phone is a consultant. And I think the reason was because a lot of registrars wouldn't accept any patients. They basically would keep them out of hospital. So the GPs couldn't get their patients in there. Whereas I think they found that with the SMOs, more patients were let in appropriately. Because, look, most GPs know when to refer a patient to hospital. I'm sure there are a few that aren't, but who might do that inappropriately. But most, on the whole, I think GPs are pretty good about sending people in when they need it.
So 6 weeks later, no investigations having been done, Mrs. A came in for a review. She again reported that she'd had this sudden onset of shortness of breath on 2 occasions during the previous 4 months. And it actually, although the acute shortness of breath settled fairly quickly, it took several days before she returned to her normal functioning. And the GP this time, and somewhat inexplicably really, didn't follow up her earlier concern that this must be a pulmonary embolus, but started investigating possible respiratory or cardiac causes for the shortness of breath. And later she wondered whether she'd misinterpreted the rejection of her CT request as maybe suggesting that investigation wasn't indicated or warranted. I mean, it doesn't really gel, but we're looking for reasons why her line of thinking went so far off track, really. And unfortunately, 2 weeks later, Mrs. A collapsed and died, and post-mortem revealed both acute and chronic pulmonary embolus. So look, there's a number of things that we might discuss between the four of us, and Adam as well. Is this an incompetent GP or a generally good one who just got one thing really badly wrong? Were there work pressures that might have affected her decision-making? And in fact, she did report that they were operating on 1.5 full-time equivalents rather than the 2.5 that they should have been at the practice. Another thing to consider is what's the impact on a good GP when they become aware of the results of their actions or inactions. And interestingly, it appears that this doctor really didn't appreciate until the time of the complaint just put it together a sequence of events. So even when she wrote the report for the coroner, really didn't put 2 and 2 together that this was a pulmonary embolus, and just said, death, no way of explaining what the death might have been from. So it was really only later that she came to that conclusion. And then just from a medico-legal point of view, what's our role, both as lawyers and medico-legal consultants, when we're advising a doctor in this situation on how to respond to the HDC request for information, when it's pretty clear, even without applying hindsight bias, that actually things didn't go as they should have gone? Thoughts on those?
That's a lot of questions right there, Tim.
All right, well, you don't have to answer all of them, Sam. You can just...
I think one of the things is, because we don't see a lot of cases with missed PE, but you do see them. And I think it's one of those diagnoses that you just have to think about. Someone comes in with chest pain, shortness of breath, think PE, and you just want to exclude it. Because if you don't think about it, you don't look.
Dr. Mapleston certainly commented on that. And in fact, he clearly had a lot of sympathy for this GP because she actually wrote good notes. She was basically a good GP, but just something went wrong on this case, and she went off the rails. And he commented more than once that diagnosing pulmonary embolus was a difficult thing in primary care, and it's uncommon too. I can only think of one pulmonary embolus that I diagnosed in my entire general practice career, and that was pretty easy because the woman came in having had a pulmonary embolus about 2 months before and said, "Oh, I've got the shortness of breath again, doc," and so it was fairly clear as to what should be done.
I just think we're all human, and actually it's so easy to sit and look at these cases and think, oh no. But actually it could have been me.
Yes.
It could have been me.
Could have been any of us.
Just thinking about something else and losing the train of where you were going and starting down another path. It's so my thoughts are, if the notes were good and all the rest, that's a good GP who's had a bad day. And look, we all have bad days. So yeah, and the work pressures thing, it probably is part of it. If you're really busy and you're flying through results and you're staying up late doing your inbox and all the pressures of general practice, and you've only got 15 minutes and you're doing telehealth consults, all those things make it harder.
So when she got that rejection letter from radiology, would that have been sort of processed semi-automatically?
Yeah,
okay,
exactly.
It's been rejected. I won't.
Yeah. What time was she doing her inbox when that rejection letter came in? And did she think, all right, well, I can't get that file, without thinking, well, what am I doing about that D-dimer of 4,000 then? It's too easy to do. It's too easy to do.
If you're under pressure like that, is there also a sense of you've passed a problem on by making that referral, and even though it was a sort of unusual response to get back, which probably required a bit of thought, there's a wee bit of reassurance. I've done the right thing. I've made a referral. It's someone else has also had a look at this. Would that be even subconsciously part of your thinking?
Even more, they've decided that actually it's not indicated, or it won't be done.
Yes, yeah.
It won't be done, therefore
that happens
may not have
a
been
lot.
indicated.
When I was reading this and I was trying to think about the psychology of it, I think you've got a problem and you've got loads of patients in a big inbox. You've done the thing.
Yeah.
Right? And then perhaps that allows you to take your focus off that patient and onto your next problem who you're worried about. And it's hard then to reclaim that responsibility and think, oh, well, actually, I don't trust the answer I've got. Right.
I think that I've seen a lot of cases where the GPs have used the triage system as a form of opinion. So when the hospital says we're not going to see them because they don't meet the threshold, the GPs have thought that means they're not worried about this patient. I don't need to worry. And so I think you're absolutely right. And if you don't have the time and brain space to think about it, then it's very easy to accept what comes back from the hospital as being a good opinion.
And I almost think that when you get those kinds of rejections from the hospital, you almost should have an automatic thought of, please tell the patient this has been rejected, and please can they make another appointment so we can discuss where to from here. And that should almost be your go-to response to any rejection from the hospital, is try and get the patient to come back, because then you've got 15 minutes to think about it. You know what I mean? And actually, because I think when you're doing your inbox, it's dangerous to make that decision then. And you need to tell a patient that they've been rejected. Obviously, this didn't happen in this case. And so having a kind of a thing in your head, whenever I get a rejection, my process is I tell the patient and I ask them to come back to discuss the next step. It's kind of a little safety net in your own brain for how you deal with them.
That's a good idea.
In terms of the question you asked, Tim, about the role of a medico-legal consultant in advising a doctor, I mean, I think we always encourage members to phone and ask for help. And that's an excellent first step, because if you are already time-constrained and then you do that first response yourself, you still might be trapped in that mistaken paradigm, and having someone who's independent but on your side to challenge you and say, well, look, can you send us all the notes? let's stop and look at the whole history of this afresh and have that perspective. It will then, even if the answer is an unhappy one, like it seems to have been a mistake here, you can start trying to address the damage of that by responding in a insightful way and turning your mind to what can be done differently, which will always be received well by regulators, the coroner and HDC included.
Yes, and in fact, in this occasion, it was one of those, I think, challenging situations where the doctor did have to make a significant shift from thinking, oh no, I covered everything, I thought I'd covered things properly, to realising, actually, no, that wasn't the case. And that's, I think, one of the roles of a medical legal consultant is to point out where vulnerabilities are and therefore how a response might be worded in light of that. And also to give a bit of an expectation of what might happen as well. So clearly when we read a case like this, we're going to say, look, I think this is very likely to go to an investigation because there's been a very bad outcome and there have been some lead-up things, so that at least our members are aware that that's going to happen, rather than the surprise letter 6 months later when they haven't heard a thing suddenly saying that they're going to be investigated.
It's a terrible feeling, I think, as a clinician to realise that you've made a significant error that's led to patient harm. None of us want that. I think it's probably our worst day when that happens. And I don't think we can underestimate the importance of how we relate to our members, knowing how hard it is for them. And I think that's one of the things that I find very satisfying in our role, is that we can help doctors through this extremely stressful process. And, to be able to reassure them that someone's with them, that, they're going to get through this and they'll be able to continue on and have a good long career, and I think that's one of the great values of what we do. And obviously we work really closely with our lawyers like Adam, and you guys provide a whole different dimension of assistance to our members, which I know they really appreciate.
But it is also includes that element of reassurance, and even if you can't make the problem go away, you can at least let people know that they're supported, and also put it in a perspective of, this is a worse day for you, but because we see so many cases, we can also, predict how it's likely to unfold, and let people know that it's not going to be the end of their career. And while sadly these things can take a long time and be a bit drawn out, there is an end point that is not a catastrophe.
I also think there's a lot of shame associated with making a mistake like that, and that often you think all your colleagues are going to judge you and think you're a terrible doctor. And to have another doctor on the end of the phone saying, I don't think you're a terrible doctor. I think that there was a mistake, but we all make mistakes. And look, this is all right. We're going to help you with getting through this process. I think that's some of what we do as well, is actually making sure not normalizing is not the right word, but actually saying this happens to a lot of, if not
so
most,
that they know
doctors.
they're not the only one.
They're not the only one. For them, because doctors don't often talk about their big mistakes. They don't talk about their big mistakes, and yet we hear the big mistakes every day. And so for us, we can say, no, I've heard, because members often come, okay, have you ever had a case that's worse than this? I think, yes, I have. They often want to be reassured that actually this has happened to other people and it's not just them, and we don't think they're a terrible doctor, and that actually.
I spoke to a member just 2 or 3 weeks ago who the comment was, I feel so alone.
Yeah.
I think because they thought this, I'm the only doctor that's ever done this. And just me being able to say, not at all. We often have this, this issue come through. She was so relieved. And I think, she, at the end of that conversation, she felt so much better. And I love being able to do that for people.
It is a nice part of the job.
It is a nice part of the job.
Any final comments on the case?
No, I think it's a reminder to stop and think, is there something else I'm missing here? Just that one step back. Am I missing something that's really important?
And I also think that when you have an abnormal result like that D-dimer of 4,000, just set a recall to what's happening about, because the problem is you send off that referral and it's kind of out of your system. You actually, I think, setting recalls to remind yourself about significant results, or to just get it to recheck it so that it comes back in your head again. But also if something is rejected, trying to get the patient in, if an investigation is the other thing. I think we have to, whenever something is rejected by the hospital, we have to think, right, now what, rather than just accepting it.
And I think there's also real importance in, when you've got someone who's got a challenging problem, you haven't been able to sort it, is to actually set aside time to go back and look at all of the information. And, as we found when it's summarised, it all becomes quite clear. And I think if this doctor had done that, she would have suddenly thought, oh, crikey, no, this has to be a pulmonary embolus unless proven otherwise. My patient needs to be in hospital.
Or take it to a peer group or a clinical meeting,
Yeah.
If you've got a result that you're thinking, why is that? Go and ask somebody else.
Phone a friend.
Phone a friend.
Well, thank you everyone for your thoughts and comments on the case, and thank you all out there for listening to this podcast, which I hope has been helpful for you. We hope you'll tune in for our next one in 2 weeks' time, and we look forward to catching up with you then. If you like these medical protection podcasts, please subscribe and leave us a review. And if you'd like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org. Bye for now.